In the next 30 minutes or so, I'm just going to briefly review some general topics as they relate to pediatric neuroimaging. So a lot of people get intimidated when they look at MRs of children, and primarily it's because the pediatric brain is more dynamic than the adult brain, and depending on the age that you're looking at, it will look very different, both with respect to the sulcation pattern and with respect to the myelination. And so it's very good to have a targeted approach that you consistently follow, so as to be able to read these cases and to not miss anything. So I'm going to share with you my approach, and I usually start with the midline image, and you see here a midline sagittal T1 weighted image in a neonate. I know it's a neonate because the anterior pituitary is bright and bigger than usually for children, and that's something you see in neonates. And the reason why I start with the midline sagittal image is because there are a lot of structures that are included on that image and that can give you a lot of information. For instance, you can look at the corpus callosum and see whether or not it has formed. You can look at the volume of the callosum, which is a reflection of the white matter volume in the supratentorial brain. You can look at the signal intensity of the callosum, which can be an indicator of myelination or even abnormal myelin. And you can look at the brainstem, which is another indicator of white matter volume, and brain, and some genetic conditions can result in brainstem malformations. And then if you're evaluating a child for a suspected brain tumor, some of the more common locations are the suprasellar regions and the pineal regions, and again, those are included on your midline sagittal image. So it's a very helpful image to start with. Beyond that, I then look at the overall white matter on typically axial or coronal images, looking again at the intensity of the white matter, which is a reflection of the myelination and can be a reflection also of abnormalities, focal abnormalities within the white matter, and looking also at the white matter volume by looking at the depths of the sulci and seeing how far they extend medially towards the ventricles. Also, I look at the surface of the brain to look at the sulcation pattern, and that I find actually is preferable on sagittal images, so I strongly encourage you to get used to looking at the sulcation pattern on sagittal images. And then I look at the axial plane to look at the deep gray nuclei in patients in whom I suspect, for instance, metabolic abnormality, or in neonates where I may expect hypoxic ischemic injury. And then lastly, look very closely at the posterior fossa structures in all three planes, the vermis, the cerebellum, and the brainstem. As you all know, MRI is really the optimal method for imaging the pediatric brain, has many advantages over CT, including obviously the fact that it doesn't use ionizing radiation. And because the pediatric brain is so dynamic, it's very important to know not just the age of the patient at the time of the scan, but the post-conceptional age. So if someone was born 2 months preterm and they are 12 months old at the time of their scan, their brain will look more like a 10-month-old. So you need to adjust the age, and we typically adjust the age up until 2 years of age. So just a couple of general comments about myelination. It does begin in the fetus. In general, the brain myelinates from a caudal to a cephalad direction, from a dorsal to a ventral direction, and then within regions of the brain, it tends to myelinate the central white matter first, and then extending out last to the peripheral white matter. There's many normal milestones to remember. I strongly suggest remembering at least the milestone of the corpus callosum, where the anterior callosum is myelinated by 4 months of age on T1 weighted images, and 6 months of age in the posterior callosum on T1 weighted images, and then T2 weighted images, you add 2 months to that. So the anterior callosum should be myelinated on T2 by 6 months of age, and the posterior by 8 months of age. And there are many, there's a lot of information out there about normal milestones. You can always refer to a textbook if you'd like for those milestones. And most of the myelination that we see as evidenced as changes on T1 and T2 weighted images occurs most rapidly during the first 2 years of life. Now, what does myelin do when you form myelin in the brain? It changes the T1 and T2 intensity for different reasons. And on T1 weighted images, the white matter becomes bright, and on T2 weighted images, the white matter becomes dark. And in general, the changes are seen first on T1 weighted images, and then later on the T2 weighted images. So here's an example of just a preterm neonatal brain and a term neonatal brain to show you how the brain is so dynamic, especially younger in age. And you can see if you compare the overall sulcation of the 34-week brain compared to the 40-week brain, you can see that the sulci are much more complex on the lower two images compared to the upper two images, and that's because secondary sulcation has progressed and tertiary sulcation is also starting to occur. So in a younger brain, a preterm brain, the sulcation pattern is more simplified, the gyri are wider. Even after term, the sulcation will continue to get more complex, especially in the frontal and temporal lobes. So if you look at the sulcation pattern very carefully, in a 6-month-old, it looks different than a term neonate. We also look at the myelin, as I mentioned, within the pediatric brain, and a term, probably the best place to look is in the posterior limb of the internal capsule, and you should see by 38 weeks gestation, in this case this is a 40-week infant, you should see a small focus of bright T1 signal intensity within the posterior limb of the internal capsule, and low T2 signal intensity also in the same location. You'll notice that the extent of myelin is bigger on the T1 weighted image rather than the T2 weighted image, and that's because there are different reasons that result in the change in signal intensity as related to myelin. The other thing just to comment on about the deep gray nuclei is that the deep gray nuclei at term are relatively iso-intense to the cortex on both T1 and T2 weighted images. The exception to that being the thalamus, and the thalamus is a bit heterogeneous, especially on the T2 weighted images, where the ventral and lateral nucleus of the thalamus is typically more hypo-intense. Now, I mention that because it's really important not to mistaken that normal hypointensity in the ventrolateral nucleus of the thalamus for myelin in the posterior limb of the internal capsule. You can see that on the posterior limb of the internal capsule, one handy thing to use is the fact that this small amount of myelin is surrounded by unmyelinated white matter, and that's how you know you're dealing with the posterior limb of the internal capsule and the corticospinal tracts on that slice. The brain will continue to mature. I mentioned how the sulcation is even different at 6 months of age, and you can tell that on this image compared to the term neonate. And at 6 months of age, you can see there's a lot more myelin on the T1 weighted image. All the deep white matter is essentially bright. With increasing myelination, the extent of increased T1 will increase, and it'll go out more peripherally into the subcortical white matter, and also the intensity of the brightness on T1 will change. By 6 months on T2 weighted images, there aren't a lot more changes in the brain, but you can see, for instance, that the posterior limb of the internal capsule now is fully myelinated on T2 weighted imaging. And we typically use about 8 to 10 months of age is the state at which myelin looks complete on a T1 weighted image, and 2 years of age at which myelin looks complete on the T2 weighted image. Okay, so now we'll just move to some pathologies that you may encounter when you're reading pediatric neuro cases. So I mentioned looking at the corpus callosum on the midline sagittal image. There's a normal image on your right, and the image on the left, we see that we can see anterior callosum, but the posterior callosum has not formed. One way to know indeed that that's because it never formed is to look at the sulci and to see that they radiate down to the ventricular surface. And that's a feature that you also see with complete absence of the corpus callosum, as in this case, where you see these medial sulci that are radiating inferiorly. You can also see eversion of the cingulate gyri. An important thing to note when you're looking at cases of absent formation of the corpus callosum or agenesis of the callosum is that a lot of times the ventricles will look large. In ultrasound, I'm sure you've heard it referred to as colpocephaly, and that's not because there's hydrocephalus, that's because there's an abnormality of white matter development development. And so in general, when you're looking at pediatric cases, you need to be careful when you are concerned about hydrocephalus. And the one advantage of a young child before the sutures have closed or the anterior fontanelle is fused is that the clinicians have other signs that they can use to determine whether or not the large ventricles that you see are indeed related to hydrocephalus. Now, abnormalities of the corpus callosum can be associated with midline interhemispheric lipomas. The most common location for congenital lipomas are midline interhemispheric, as is the example here. They can also occur in other locations like quadrigeminal plate cistern, suprasellar region. These are do not touch lesions. These should not be operated on surgically. If you do fat saturation, you'll see that they nicely suppress. Other lesions that can occur in the suprasellar or hypothalamic areas are hypothalamic hamartomas. They can be pedunculated or sessile. They should follow gray matter on all your sequences, and they should not enhance. Now, in the radiology literature, we're typically taught that these hamartomas are associated with gelastic seizures. It's important to note, however, that you can have other types of seizure semiology associated with gelastic seizures. So I teach my residents and fellows that when they are looking for a seizure focus on an MR scan of a child with epilepsy, the last thing you should always look at is the hypothalamus. And when they're very sessile, they can be tough to see, so you need very thin section, high resolution imaging in order to evaluate for the possibility of a hypothalamic hamartoma. We're just going to switch into some malformations of cortical development, and it's important to remember that embryologically, the cells that will become neurons and be located within the cortex originate from the germinal matrix, which classically is in the ventricular zone, so in the walls of the ventricles, and they have to make their way out to the cortex and then get organized within the six-layered cortex. When they don't make their way out to the cortex, you can end up with lissencephaly. This is an example of classical lissencephaly, where essentially you have no sulci that have formed. You maybe have very rudimentary sylvian fissures. And we can see here not only is the sulcation pattern of the brain very abnormal, it doesn't even look like a term neonate. It maybe could look like a 16-week fetus, if we know that wouldn't be possible for this infant to survive. But in addition to the abnormality of the sulcation pattern, you can look at the parenchyma. This is a term neonate, and you can see that it's very abnormal, right? We talked about how at term, your white matter should be bright on T2 and dark on T1, and we can see that it looks very different here. And instead, what we see is this large, thick band of arrested neurons, which is associated with classical lissencephaly, and superficial to that, we have a cell-sparse zone, and then we have a very thin cortex overlying that. So these are neurons that haven't made their way out to the cortex. Now, when you don't have severe lissencephaly, and it's a little more variable in its severity, we oftentimes refer to that as incomplete classical lissencephaly, where you can have some areas that are more agyric, like the one I showed you, with essentially no sulci and no gyri, or pachygyric, where there are too few sulci and the gyri are too broad. And this is classically associated with mutations either in the LIS1 gene or in the double cortin gene, and there's a gradient of severity, where this example, the example here is an example of a mutation in the LIS1 gene, where the lissencephaly is more severe posteriorly, whereas the double cortin gene mutation has more severe lissencephaly anteriorly. Now, if you look at the children of people who, if you look at the mothers of children who have incomplete classical lissencephaly from the mutation in the double cortin gene, you can actually see a different manifestation, and you can see band heterotopia, so a different type of migrational disorder. And in this case, depending on which cell had the X chromosome activated or not activated, you will see a variability in the degree of abnormality, and you essentially see a band of gray matter cells that are sitting in the white matter with a relatively normal overlying sulcation pattern. Now, if the cells never leave the germinal zone, as I mentioned, the ventricular zone, which is in the wall of the ventricle, you'll end up with periventricular nodular heterotopia. And these can be epileptogenic. They classically, again, should follow gray matter on all sequences, and that's because they are gray matter. And they're typically parallel to the long axis of the ventricle, but they can also protrude into the ventricle. And they should not enhance, obviously, because we don't expect gray matter to enhance. Now, polymicrogyria is another type of malformation. This is an abnormality in the organization of the neocortex, and it's characterized by far too many small gyri. It's best seen on very thin section imaging. Its appearance can change depending on the state of myelin of the underlying white matter, but it's important to look carefully for this in a child who presents to you with either epilepsy or with developmental delay. And these lesions are probably more commonly acquired rather than genetic. They can occur from injury in utero, either an infarct in utero or even an infection in utero. And so it's very important, even in a non-known genetic condition, to look very carefully. I mentioned congenital infection as a cause of polymicrogyria, and so this is a young infant who presented with seizures, and we can see that there are some calcifications in the parenchyma, so we're thinking about congenital infection. CT, as I mentioned, is not as good as MRI for looking at the pediatric brain, and especially when we're trying to assess the sulci, it can be very challenging on CT. But one of the things we can look at is we can look at the sylvian fissures on CT, and if we notice that they are too wide or if they extend too far posteriorly, we need to be suspicious that there may be an abnormality involving the cortex that lines the sylvian fissure and suggest an MRI. And in this case, in the same patient, we can see that there are many, many small gyri, very diffusely, not just in this perisylvian region that we noticed on the CT, and this is diffuse polymicrogyria with white matter abnormalities from a congenital CMV infection. Now, when you have injury to the cortex, you end up with polymicrogyria. When you have injury to the entire cerebral mantle in utero, you end up with schizencephaly. So schizencephaly is basically a defect through the entire cerebral mantle. So you end up with CSF that extends from the ventricular system to the subarachnoid space. Sometimes there can be a membrane overlying the lateral aspect of the schizencephaly, so you can get some mass effect and some CSF accumulation there. And these clefts are lined with gray matter, but they are dysplastic gray matter. They can be open-lipped, as is on the image on your left, or closed-lipped, where the walls of the schizencephalic defect are more closely opposed. They can be associated with absence of the septum pellucidum, and the severity of the lesions depends on their size and depends on their location, because obviously where they have formed are areas where there is not normal brain function. Okay, we're going to switch to some posterior fossa malformations. So Chiari-1 is an abnormality which you're probably more likely to see in young adults. Potentially you could see them in older children. Most of the cerebellar growth occurs after birth, so you're not going to see a child present with a Chiari-1 malformation in the first year of life. That would be very rare. But a Chiari-1 malformation is characterized by low position of the cerebellar tonsils. We typically draw a line from the basion to the opistheon, and when the cerebellar tonsils project 5 millimeters below, we're concerned about a Chiari-1 malformation. But it's important to note that there can be other reasons why the cerebellar tonsils are projecting too low. And so for that reason, you should look at the morphology of the cerebellar tonsils, especially in a coronal plane, and see if they're pointed. You should also look for some of the bony anomalies involving the clivus and the cervical spine, like segmentation anomalies that you may see associated with a Chiari-1 malformation. And the other causes you should think about with a Chiari-1 malformation obviously include a mass or increased intracranial pressure. I think that's pretty easy for most of us to make that diagnosis. And the one that's a little more challenging is intracranial hypotension. And so in order to make the distinction between the two, you need to look very carefully at the CSF spaces within the posterior fossa, specifically ventral to the brainstem. And you can see the image on your left is a Chiari-1 malformation. The lower images on your right are of someone with intracranial hypotension that has caused some descent, not as marked as the image on your left, but some descent of the cerebellar tonsils below the foramen magnum. But importantly, you can see that the CSF in front of the brainstem is effaced, and this brainstem really looks like it's slumped in the posterior fossa. The distance between the top of the belly of the pons and the mammillary bodies is decreased. The mammillary bodies and the floor of the third ventricle actually look also like they are slumped over the posterior aspect of the bony sella, very different from this appearance. And if you also might notice an enlarged pituitary, and if you give contrast, you can see diffuse dural enhancement. And if you look at the dural venous sinuses, especially the transverse sinuses in the sagittal plane, you'll notice that they are dilated and they are convex outward in all margins. If you suspect that a child has a Chiari-1, but you're not sure if it's intracranial hypotension or not, a lot of times I'll recommend that they get a follow-up scan to see if the finding is static or if the finding has resolved, because we've seen cases that are initially thought to be a Chiari-1, that then you image the child 3 months later, or the young adult several months later, and actually the findings have resolved. Chiari-2 malformation also is characterized by a small posterior fossa, but the small posterior fossa in Chiari-2 malformation is because there is a large CSF leak that has occurred in utero, and that's because the bony elements have not formed. You have an abnormality in the development of the spinal canal, leading to free communication of CSF with the amniotic fluid. And this essentially results in an intracranial hypotension picture in utero, which explains why it looks like this when we image them as children. And so classically, we'll see a small posterior fossa. The cerebellar tonsils may go very low. Most cases are associated with some type of dysgenesis of the corpus callosum. When you repair, this is a fetal image, by the way, on your lower right. When you repair this defect postnatally, it's usually associated with a subsequent development of hydrocephalus. And if you look at axial images, you can see the small posterior fossa. You can see how the cerebellum is slumped down and wrapped itself around the medulla. Other findings are interdigitation of the gyri. You can get some cortical malformations, but they're not as common. And you can have syrinx within the cord, also not that common. Another finding you may see is beaking of the tectum. So when you see this is a very classic appearance for a child who has a Chiari-2 malformation, and you'd want to know, did they have a spine abnormality that was repaired at birth? Now at UCSF, we actually repaired these lesions in utero, and the brain does look better after you fix the CSF leak in utero, and the Chiari-2 malformation is not as severe. Okay, Dandy-Walker malformation is kind of a grab bag term. When you see a large posterior fossa that's filled with a cystic CSF collection that communicates with the fourth ventricle, it's appropriate to use this term. It's associated with varying degrees of abnormality of the vermis, and it's very important in these children to look for additional malformations, as that may shed more light as to the child's development. And now we're going to spend some time on phacomatoses. Neurofibromatosis type 1 is the most common type of phacomatoses, so it's the one you're most likely to encounter. And in these children, we typically look for brain tumors. And in particular, one of the more common locations that they are likely to have a brain tumor, which is typically a glial cell tumor or a glioma, is in the optic pathway. They can occur anywhere from the optic nerves to the optic chiasm, and even extend posteriorly into the optic tract. So it's important to look all the way along the visual pathway. Even if you don't see any evidence of an optic pathway glioma, these children are routinely screened at least yearly, if not twice a year, with ophthalmologic evaluation, because they are at high risk for getting optic pathway gliomas. And indeed, 20% of these children will ultimately develop optic pathway gliomas. And when you see a scan with bilateral optic nerve gliomas, it's pretty much pathognomonic for NF1. Now, these children can also get gliomas in other locations, and brainstem is probably the next most common location. In this child, there's an enlargement of the pons. There's a pontine glioma, as well as of the medulla. Now, NF1 kids are a little bit different from other children in that other children, when we have a brainstem glioma, it's usually the pontine glioma, the diffuse infiltrating pontine glioma. In NF1 children, it's more likely to be in the medulla or in the midbrain. Now, I mentioned that they have gliomas, but if you look at their brains, you'll see many abnormalities, not just confined to the optic pathway, and they may or may not be brain tumors, and they're more likely to not be brain tumors, in fact. And so that's one of the challenges in evaluating the brains of children with NF1, is try to decide which areas are gliomas and which areas are areas of what we call myelin vacuolization or abnormal myelin. And there are a couple of clues that we can use. First of all, the areas of myelin vacuolization typically are seen within the first decade of life and then should regress, should not persist, and should definitely not show up as you're a teenager. If a new lesion appears as a teen, you very much have to worry that it's a glioma. That's one fact we can use. Another is that these areas of myelin vacuolization don't have any mass effect. So if you have mass effect, you have to be concerned that it's a glioma. Another is that these areas of myelin vacuolization are relatively iso-intense on T1. They're not hypo-intense. So if you have T1 hypointensity, you have to suspect that it may be a glioma. And lastly, if there's enhancement, that is consistent with a glioma. These kids can have plexiform neurofibromas, as shown here on the image on your far right, and they have about 5% of them will have vascular abnormalities, most classically moya, which can be progressive, but they can have all types of vascular abnormalities. Now, NF2 is different from NF1. This is a phacomatoses where you typically have nerve sheath tumors. You typically have schwannomas, meningiomas, and look very carefully along the cranial nerves. In this case, there are bilateral nerve sheath tumors in the IACs. There's also involvement of the trigeminal nerves in Meckel's cave, and this child also had a tumor within the spinal cord or an ependymoma. Tuberous sclerosis is another phacomatoses, oftentimes will present young with infantile spasms. This is also autosomal dominant disorder like NF1, and the majority have brain involvement, again, often presenting with infantile spasms or another type of epilepsy. They are characterized by tubers within the brain parenchyma, which look hyperintense in the myelinated brain on the T2 weighted images, and about a third of them will actually have gyral expansion. These are not tumors, but rather areas of dysplasia. When the dysplasia extends all the way from the cortex down to the ventricle margin, we call them transmantle dysplasias. And they can also have these dysplastic nodules along the walls of the ventricles. And we are particularly concerned when these nodules occur near the foramen of Monro, because they can enlarge and they can lead to hydrocephalus because of obstruction of CSF drainage. These children can also get globe abnormalities. They can get hamartomas of their retina. This is just a CT exam showing you actually a retinal hamartoma that is calcified and some calcifications of these subependymal nodules. The lesions of TS will calcify classically as the children get older. And I showed you previously a young infant who had tuberous sclerosis. This is a neonate with tuberous sclerosis where the brain is not myelinated, only to show you that the intensity of lesions in the unmyelinated brain is essentially, you can think of it as opposite to the intensity of the lesions in a myelinated brain. And so this is a T1 weighted image here, a T2 weighted image here in a term neonate, a fetus T2 weighted image. This child has TS, this fetus has TS. And you can see that the lesions look bright on T1 and dark on T2. And this is because compared to the unmyelinated brain, this is their signal intensity. It's not because of hemorrhage, and it's not because of calcification. Now, Sturge-Weber syndrome is another phacomatoses that you may encounter. If you're doing a CT for a child with seizures, you may see some atrophy of the cortex, and it later will be associated with cortical calcifications, and this will be progressive if you scan the child later on. You can see here the same finding on MR with injury to the cortex. There's also prominence of the CSF spaces and low T2 signal within the parenchyma because of changes related to this peel vascular malformation. If you give contrast, you can see diffuse enhancement of the pia. This is essentially a peel angiomatous process that is occurring, and it's typically associated with enlargement of the ipsilateral choroid plexus and prominence of alternative methods of venous drainage. So you'll see oftentimes dilated medullary veins. We'll talk a bit about acquired injury now. This is an ex-preterm infant who was imaged for static encephalopathy and diplegia, and we can see that there's thinning of the corpus callosum, especially posteriorly. When we look at the T2 weighted images, we can see that the sulci go all the way down towards the ventricle margin, and there's also some gliosis in the periventricular white matter. This is a common injury for preterm infants. Here's an injury for term infants from severe hypoxic ischemic injury, and we can see here's a T2 and a T1 weighted image compared to a normal term infant. We have absence of the normal bright and dark T2 signal within the posterior limb of the internal capsule. Indeed, the thalamus even looks slightly bright. It's hard to identify that, so you can look at your diffusion weighted images, which show reduced diffusion in the thalamus and in the dorsolateral putamen. At term, if you do a spectroscopy, you'll see that there's a lactate doublet in these cases. When the lactate to NAA ratio is greater than 0.3, it's associated with a worse outcome. If you do a follow-up MR, you'll basically see gliosis in the ventrolateral thalamus and the dorsolateral putamen. Just one comment about stroke in children. They can occur from many, many different etiologies, including complications of meningitis. Okay, so keep that in mind. And when you have something that looks like stroke of varying ages in non-arterial territory distributions, you need to think about metabolic disorders. Namely, you need to think about MELAS. And you may want to ask if the child has been developmentally delayed and if there's any sensory neural hearing loss. And lastly, when you're evaluating a child for trauma, if you see bilateral subdural hematomas or hematomas of varying age, you need to look also obviously for bone injury, but you need to think very carefully about non-accidental trauma and even look at the globes, especially on your susceptibility weighted imaging, as we've seen cases of retinal hemorrhage that is picked up on the MR before the child has even been examined by an ophthalmologist. Okay, so we went over some normal brain development, some malformations, including phacomatoses, as well as some acquired injury.